achieved leadership positions in public health. I'm sure there are many of you in the room who have been touched professionally or personally by Dr. Torrens. His vision to create a community forum to discuss issues in public health is why we're here today. This speaker series was inspired by him and now bears his name. Tonight we have a special session focused on healthcare management. To begin the evening, we will spotlight both the Fielding School's new Center for Healthcare Management and the Paul Torrens Chair for Healthcare Management that is housed within it. We'll also thank and acknowledge the donors whose vision and generosity made both the center and the chair possible. We'll then transition to the second part of our evening. And we'll have a special guest, Dr. Sachin Jain, President and CEO of CareMore Health, in conversation with Dr. Leah Vriesman, the co-director of the Center for Healthcare Management. The Center for Healthcare Management exists to bridge academia and practice. We want to advance the dynamic field of healthcare management, and we see 4 key roles that the center can play. First, as the builder of strong relationships with the Southern California healthcare management community, we'll pull together the best minds from both UCLA and the community to improve the current state of applied research, knowledge, and practice. Second, the center serves as the home of interdisciplinary academic healthcare management resources from across UCLA, both for students and faculty. It will provide an academic home for leaders in the field to contribute career experience and mentorship. Third, the center is the brand of healthcare management for the UCLA Fielding School's Department of Health Policy and Management and its UCLA partners. Last, but certainly not least, the center houses the Paul Torrens Chair in Healthcare Management, and the chairholder will deepen our already considerable expertise in this area. One of the center's first undertakings was to create a case competition to provide learning opportunities for graduate students and actionable solutions for sponsoring healthcare organizations. In a case competition, participants compete to develop the best solution to a business-related case study within a given time frame. In this case competition, student teams had one long weekend, 88 hours, to create a direct-to-employer strategy for UCLA Health. UCLA Health provided premier sponsorship. We're very grateful for their generous support, and I'd like to offer a special welcome to the UCLA Health folks that are joining us this evening. 35 teams from around the country competed in that first round. The top 8 teams will be arriving in Los Angeles on Thursday. It's a busy week for us in the center. The semifinals and finals will both take place here at Ronald Reagan on Friday. We're very excited about the competition and excited about the quality of the competitors that are participating. Now it's my pleasure to introduce Dr. Ron Brookmeyer. Ron is professor of biostatistics and has been serving as the school's interim dean for the past 15 months. After a nationwide search process, I'm thrilled to introduce him tonight as Dean of the School of Public Health. Ron, congratulations on your appointment.
Laura, thank you. And Laura, thank you for everything you are doing for the school. Incredible the things that you are accomplishing. It really is an honor for me to be the dean, and what a terrific evening this is. I am thrilled to be here to help celebrate the founding donors, the visionaries of the Fielding School of Public Health Center for Healthcare Management and the Paul Torrens Faculty Chair for Healthcare Management. Tonight, I want to acknowledge the extraordinary friends and donors of our school who had the vision and made the chair and the center a reality. Richard and Patty Sinaico and Greg and Marcy Sinaico established the Center for Healthcare Management with a generous lead gift through the Sinaico Innovation Fund. Richard, a healthcare executive, founded Sinaico Healthcare Consulting, and together with his sons, grew it into one of the nation's most successful healthcare consulting firms. He served on the Cedars-Sinai Medical Center Board of Governors. An alumnus of the Fielding School, Richard has served for many years on our faculty, teaching healthcare financial management in the executive MPH program. He is a devoted mentor to our students. He serves on the Fielding School Board of Advisors, and in that capacity, I have been fortunate to be able to work with him. Richard, I want to say how much I've come to value your friendship, your advice, and your thoughtfulness. Greg Sinaico, Richard and Patty's son, is also a Fielding alumnus. Greg founded The Coding Source, a leading provider of clinical coding and related services for healthcare providers. The company grew into an industry leader under Greg's leadership as CEO. We are so grateful to the Sinaicos for their vision and their gift that will have a lasting and great impact for our students, our alumni, our faculty, and for healthcare. Richard and Greg are here with us this evening. Please stand to be acknowledged. Thank you so much. And now to the Paul Torrens Faculty Chair in Healthcare Management. The chair, housed within the new center and the Department of Health Policy and Management, will help attract top scholars to UCLA. I am so grateful to the Don Levin Trust and Tom and Edna Gordon for their generous gift to establish this new endowed chair. Tom Gordon, a UCLA graduate, is the chairman of the board of DSL Construction, co-trustee of the Don Levin Trust, and consultant to the president at Cedars-Sinai's health system. A longtime preceptor, mentor, and teacher in the Fielding School Executive Program in Health Policy and Management, Tom has helped countless Fielding students launch their careers and has provided them with invaluable guidance and inspiration. He serves on many boards, including the Cedars-Sinai Medical Group, Cedars-Sinai Medical Care Foundation, and the California Association of Physician Groups. Tom serves on the Fielding School Board of Advisors, and through the board, I have been fortunate to get to know and work with Tom. Tom, thank you for your friendship, your vision, your sense of humor, and your energy that gets things done. Dr. Torrens was deeply moved by the creation of the chair, a meaningful and beautiful tribute to the incredible contributions of Dr. Torrens to our school. Tom is with us tonight. Please stand so that we can acknowledge your vision, your generosity, your commitment to the school and its mission. Thank you so much. I also want to acknowledge and thank our alumnus, Dr. Artie Southam, and his wife, Dr. BZ Daly, for their generous support of the chair. We are honored to have Artie and BZ here with us this evening. In addition, the center and chair have received numerous gifts from individuals, including those who are Tom Torrens's former students and colleagues. Their names are listed in your program. I am grateful to all the donors who have supported the center and the chair, and we extend a special welcome to those of them who are here with us tonight. I want to thank and acknowledge Dr. Jack Needleman, Chair of our Department of Health Policy and Management, as well as Dr. Laura Erskine and Dr. Leah Reisman, the Center's co-directors. This would not be possible without you. The Center and the Torrens Chair enrich the Fielding School and our university and will make a positive, lasting difference for healthcare for years to come. And now I'd like to turn the program over to Hannah Assad Zaidi, an alumna and a member of the Paul Torrens Health Forum Planning Committee.
Thank you, Dr. Brookmeyer. So as a board member of the Health Policy and Management Alumni Association and a member of the Paul Torrens Forum, I'm very honored to have participated in tonight's planning and to be here tonight. It's really exciting to look around and see a room full of students and young professionals, executives, mentors come together to have a dialogue about critical issues in healthcare. That is the spirit of the Paul Torrens Forum, so we are very thankful for your support and for your engagement. So in preparation for tonight, there was a lot of brainstorming around potential topics for discussion. There were a lot of ideas. There's a lot going on in healthcare. Healthcare is in the midst of a major transformation. We are preparing for a technology-driven future, for changing consumer demands, for an evolving workforce, an aging population, and the list goes on. We have upcoming presidential elections later this year, and healthcare is really one of the most important social and economic issues that are up for debate. So what better way to dive right into this discussion than to have two very prominent leaders in healthcare tonight to have a conversation about healthcare. So Dr. Leah Reisman has many roles at the Fielding School. She's an associate professor, director of executive programs in health policy and management, and most recently co-director for the Center for Healthcare Management. Dr. Reisman is an expert on healthcare innovation and transforming healthcare systems. As an associate professor and the director of executive programs in health policy and management, Dr. Reisman teaches strategic management of health services organizations, international comparative health systems, and speaks often on health technology and innovation. She specializes in leadership development for hospitals, health systems, medical groups, biotech and pharmaceutical organizations. She's a Fulbright grant recipient, a German Scholar Exchange Award winner, and a very admired professor at the Fielding School. So Dr. Reisman will be facilitating the discussion this evening with our esteemed guest, Dr. Sachin Jain. Dr. Sachin Jain is president and CEO at CareMore Health and Aspire Health. Dr. Jain leads an integrated delivery system that spans 12 states and hit more than $1 billion in revenue in 2018. Under his leadership since becoming CEO in 2016, CareMore has bolstered its work on addressing social determinants of health, pushing for better integration of behavioral health and physical health, and forging innovative partnerships with companies such as Lyft. Dr. Jain, selected by Modern Healthcare as one of the most influential clinical executives, also worked in the Obama administration from 2009 to 2011. He is also a consulting professor of medicine at the Stanford University School of Medicine and a regular contributor at Forbes. Dr. Jain is co-founder and co-editor-in-chief of the journal Healthcare, the Journal of Delivery Science and Innovation, was elected to the National Academy of Social Insurance in 2010. He is a Harvard alumnus where he received his BA, his MD, and his MBA. and continues to practice medicine at CareMore. So it is my pleasure to introduce Dr. Leah Vriesman and Dr. Sachin Jain.
So, good evening. I'm going to be using a handheld. Oh, good. It works quite well. So there are so many things that I would love to be able to talk with you about tonight. But given the spirit of the Center for Healthcare Management and the fact that we're bringing together scholars, practitioners, and trying to create a home, we're going to concentrate a little bit on Sachin's approach and marriage of both a practitioner as well as a scientist. So if you're up for that, I'm going to give you a few questions and let you go from there. I have some questions here, and I definitely want to give Dr. Jain the opportunity to answer these, but then I am very interested in moderating a Q&A for all of you. So if you have some ideas or some questions from what comes out of this, I look forward to hearing from you all. So first of all, let's start off with the question of how did you blend both your background in health services research as well as medicine and management together and keep that an active blend as you go forward in your career?
Thank you for the question. And first of all, thank you all for coming tonight. It's a Tuesday night.
You may not be on.
Oh, sorry.
Whoops.
Scream if you like.
It's pretty good audio in here.
So first of all, just thank you all for coming out. It's a Tuesday night. You have a packed auditorium, so I don't know what that says about me or you, but says something about all of us, I think. But really grateful to be here and grateful to kind of kick off this speaker series. You know, the question's a really interesting one. I started my career as a government major in college, went to medical school thinking I would try to change healthcare through a blend of health services research, clinical practice, and work in policy over the course of my career. And something happened kind of along the way, which is I got really impatient. I actually got David Blumenthal, who was a professor at Mass General at the time, was writing his book on the history of health policy in the American presidency. And he asked me to research George Bush Sr.'s presidency in health policy. And this was around 2002, maybe 2003. And I started to kind of read all these articles about what the health policy discourse was between 1988 and 1992. And I realized that it was like all the same people saying all the same things as they were 10 years later. And I thought, man, you know, the best I could do is maybe I could be one of these people. But ultimately, you know, these folks are not changing the game. And the numbers, you know, the main thing that was changing was the number of Americans who lacked health insurance or didn't have health coverage. And I thought, you know, the odds that there's going to be a president who's going to be able to enact national health care reform is very low. That was what the book was really about. So I said, you know, the best way to change healthcare is at the local, institutional, systemic level. And so I diverted my path completely, and I ended up doing an MBA. And then President Obama was elected. And all of a sudden, there was this incredible platform for change. I think the training as somebody who's kind of trying to be a health services researcher, learning to practice medicine, understanding the business of healthcare was remarkably useful, because I think this healthcare system is so complicated and so difficult to understand. And so being able to view it through the lens of, you know, how medicine is practiced, how policy is shaped, how organizations are organized and structured to deliver particular outcomes, really I thought gave me a unique vantage point that allowed me to kind of think holistically about how healthcare is delivered. And I would say I still have kind of huge gaps in kind of my perspective that I continue to try to fill in. But, you know, I think that you can't actually do one without the other. And I always talk about doctor-hating economists and economist-hating doctors, because, you know, ultimately I think a lot of the sort of dialogue around how we should change our healthcare system, how we should organize and structure our healthcare system is often not informed by appropriate insights. And so I think, you know, efforts like the one that you're leading now here in the center, are really, I think, remarkable because they create a platform where people who practice can work with people who do research, who can work with people who lead systems. And all of those are different perspectives. They're complementary perspectives, but they're different perspectives. And so, I'm a huge believer that evidence should inform how we organize and structure healthcare delivery. But that's not necessarily something that most people who are in positions to lead healthcare systems actually believe. They're kind of guided by, that sort of one pure number, which is like your operating margin. And unfortunately, that's only like a part of the story, right? And that is only a part of the story and I can say that convincingly as a physician. The most important thing is that we actually deliver great care to patients, and that should be our true north. And again, I think these conversations get confused because we just bring so many different perspectives to the table. And so I think the job of all of us who are trying to change healthcare right now is to get real, whether you're a physician, non-physician, nurse, whatever your role is in the system, is to really kind of be curious. Take a step back and just be curious about why things are the way they are. Because I think if we do bring that curiosity, there's this incredible opportunity for us to create real change, and change that's informed by the whole instead of kind of the unique interests of whatever that little thing is that we're doing at that time.
Great. When you talk about bringing evidence forward, it can be evidence in the clinical practice, it can be evidence in management, it can be applied evidence, it can be theoretical evidence. Right now there's a big trend in a lot of universities, including our own, talking about translational science. And basically what that simply means is taking what we learn in research and actually putting it into play. So how would you define, given that you play these different roles, this idea of health system delivery science, and what impact can that make in today's actual delivery of care?
So I think healthcare delivery science is this like new term. I was actually around like this group of people, this is about 2009 or 10, who were like, we need to invent a new science of how healthcare is delivered. And we were like, oh, we've got to, define what this science is. And I've now been to 3 conferences. We've started a journal on healthcare delivery science. I don't know what healthcare delivery science is. What I can say is it's this kind of perspective that we all need to bring to the delivery of care, which is reflective in terms of analyzing data to try to understand what's actually happening, and then using that data to actually define how we manage systems. And what I can tell you is, if I were kind of building a healthcare system from scratch, I would have a chief research officer reporting to the CEO who is actually tasked with studying the system. And there's versions of this that are popping up across the whole healthcare landscape right now. Humana just announced it's appointing a chief data officer. And I think these are attempts to get a look at the data, to try to understand what's happening, to then inform practice. I think the challenge is that we've kind of bought into this whole like no mission, no margin thing. And I think no mission, no margin is like a really great excuse that organizations use to be lazy about kind of balancing all the different missions that you actually have. And so margin ends up being the kind of key thing that you measure and assess. And then we get very lazy about for-profit versus nonprofit. And the reality is everyone's acting the same, but it's just one person has a different title in front of their organization's distinction. And I just think we have to get way more honest about what's happening. And that honesty really can be accelerated through a look at the data and through kind of developing these more informed perspectives that actually come from evaluating the data. And that's something, we are not perfect at, even in the organization that I lead, but it's something that we strive to be perfect at. And we ask ourselves a lot of questions like, are we living up to the words on the wall in our organization? I mean, we all spend a lot of time crafting these fancy mission statements, and then we do what we do. And I always say the cynicism that exists in so many of our organizations is the gap between the words on the wall and then the practice that we all experience every day and that our patients experience every day. The difference between A+ organizations and C- organizations, and there are really only 2 kinds of organizations, I think, is that the A+ organizations are at least trying to live up to the words on the wall. And so I think that's delivery science can be this kind of enabler of actually trying to get to that place of, are we really fulfilling our mission? Are we really doing what we need to do to serve the communities that we want to serve.
As a strategy professor, it just hurts to hear you say that people aren't following their mission. Okay, so outside of that challenge, the no mission, no margin, and kind of the robotic just going through the motions, what other challenges do you think are really facing health services research, healthcare management, either as silos, but also as them needing to come together?
Yeah, I think there's this huge crisis of relevance, right? So you've got the producers of health services research, and then you've got the consumers of health services research, and they're actually not connecting. So I had this my first summer internship in college was at something called the Alpha Center. Does anyone know what the Alpha Center is? Oh, wow, that's amazing. Jack Needleman knows who the Alpha Center is. That made my day. So the Alpha Center is a small little think tank, got absorbed into Academy Health, and no one's ever heard of it ever since. But I spent my first summer in college working at the Alpha Center, toiling away in a back room somewhere. And I just kind of believed that the work that I was going to do was somehow going to get published. It was published. And then people would read it, and then the world would change because people read it. And what I find is all my friends who've kind of stayed in this health services research world still believe that. They're like, oh, if I just publish it in the New England Journal or JAMA, the whole world is going to read it, and everything's going to get better. And the funny thing is that that's just not, my 2 years in Washington, I just realized that there weren't legions of people just waiting to read this week's New England Journal. And so, I think that there's this big crisis of relevance. And I just don't think we train people who do health services research to actually understand how the world actually changes. And I think that there's this extra skill set that we have really failed to teach people, which is understanding the world around them and then being able to apply what they know to drive change. And so I think that's the biggest gap, I think, in the field. So you've got a lot of what I would say dead weight loss. We're producing a bunch of stuff that no one's using. And that's the translation gap that I think we need to close. And the truth is that we can close it. Like every one of us can actually close it, right? If we actually start to kind of integrate the insights that others are producing into practice. And I was really hopeful, I was part of the founding team at CMMI, and I was really hopeful CMMI would do that. I think it's one of the kind of key opportunities. And I know Brad Smith, who's the new CMMI director, is really focused on this. Is like, how do we stop this craziness of reinventing and rediscovering things that we already know to be true, just in different evidence, with different evidence-based, different sandboxes. We have an industry that self-perpetuates itself by creating distinctions without a difference, right? That's kind of the challenge that we need to really solve. And so I think that's the challenge. That's what the health services research enterprise really needs to do. And I think, on the flip side, the management enterprise needs to start paying attention to the health services research enterprise and start to ask questions like, what does health services research tell us about how kidney care should be organized? Well, it tells us a lot, but somehow it never gets actually implemented in practice in terms of how we do vascular access, whether we do PD before we do HD. All of these things just don't, and just to kind of go take it a step further, part of it is just, we don't have, I would say lots of health systems leaders don't necessarily have a deep understanding or respect for health service research. They also don't have a deep understanding or respect for clinical medicine. And clinical medicine ends up getting this kind of secondary or tertiary or quaternary voice in terms of how we actually organize and structure the delivery of care. And so I really believe clinicians need to kind of play a much bigger role, but in order to do that, they need to get the kind of training that you guys offer here.
Fantastic. I was so mesmerized, I forgot to pick up my microphone there. So can we go back a little bit to Academy Health? So for those of you who are practitioners who might not know, Academy Health is really a premier health services research forum. Just as all of you go to conferences through your professional associations and organizations, Academy Health is the premier health services research forum. And you are working closely with them since the Alpha Center, I believe, to promote healthcare innovation. Can you talk a little bit more about your partnership with this? Because it's pretty unusual someone running an organization like CareMore have such a close relationship and partnership in thinking about health services research.
Yeah, so the partnership is really with our journal, which is Healthcare, the Journal of Delivery Science and Innovation. And it's really around kind of trying to get at this question of how is it that we can get the right evidence into the hands of the people who actually can use that evidence to drive changes in practice. And Lisa Simpson, who's the CEO of Academy Health, I think is really interested in this question of how do we become relevant as a field, and kind of create this translation gap. So a lot of what we're doing with the journal is trying to think about kind of new format innovation in terms of the kinds of articles that get published, and thinking about the different dissemination vehicles so that when something does get published, it actually gets into the hands of the people who can actually act on it, as opposed to sitting on a shelf or sitting in PubMed, growing your CV, getting you tenure, but not necessarily changing the world. I mean, that's the, so.
Is that open access?
So
Sorry, that wasn't one of my questions.
No, and it's a fair question. The journal is owned by Elsevier, and I know you guys have a great relationship with Elsevier at UCLA. So
yeah,
I'm just
UCLA is fighting Elsevier
yes,
right now as a publication access, but it really sounds like something that the center should look into, because we really. That is exactly the intersection that we are talking about and how to get that word out.
Love to partner with you on it.
Okay,
Absolutely.
fantastic.
Yeah.
So let's switch to CareMore a little bit. But still staying with the theme. How are you leading an organization that has such a delivery system focus, has your own metrics and your goals, and yet you care obviously so much about using evidence-based management, evidence-based research? How can you bring that, which I think a lot of people who are practitioners here might be asking themselves, how do I bring this into my organization, have people take it seriously, and bring that marriage together?
Yeah, so we're not resourced to kind of house a health services research institute per se, but what we are able to do is actually partner with people who kind of know how to study our data. And so we have relationships with the University of Pennsylvania, with Harvard, would love to have one with you all, around looking at our data and asking very specific questions of interest to us, and then using some of the insights from that data to drive changes in practice and how we operate. So the best example of this was several years ago, one of our physicians, as the price of insulin skyrocketed, had this insight that human insulin might work just as well as analog insulin. There's no reason from the literature that it wouldn't in diabetics. And as the cost of analog insulin was going up, he thought maybe we could switch everyone to human insulin. And so we did this at scale. I mean, this was something we just implemented all at once. We literally hired a number of pharmacists and we just converted everyone. But the question that we had to ask is like, did we actually do a good job? Like, and does it actually work? And are people maintaining normal glycemia? And we studied it, we were pretty satisfied, but then, we decided it wasn't good enough that we studied it. So we partnered with Aaron Kesselheim and Jing Liu at the Division of Pharmacoeconomics and Epidemiology at Brigham and Women's, and they actually studied our data and published it in JAMA. And again, I think, basically took a strategy that we implemented and open sourced it for the industry, right? And that's the kind of thing that I think we just need to do more of. Is validate the things that we're doing, some of the harebrained things that we come up with sometimes, and then, basically open source it for the industry. And so we're similarly studying our ESRD outcomes, which is just, a very hot topic now as Medicare Advantage is now being modified to serve patients who are ESRD, who have end-stage renal disease. So these are all, I think, very highly practically relevant questions that we're trying to answer, and then open source for the industry so that we can actually catalyze the kind of change that really needs to happen.
Great, fantastic example. I have one other question. I don't know can you raise your hand if you are a physician in the room? All right, so we have a few. One of the things that in my area of strategy and innovation and leadership that I've had so many discussions about is the new care team. And Sachin has written a very interesting article published in Healthcare called Invisibility and Modern Medicine. And we'll link it on this simulcast when we post it on our Fielding website. It's not a long read, but it raises a really important issue. And as a physician now, I'm going to change your hat again. As a physician, you make an argument about what's happening to the physicians in providing care, the role that they play in the team of care and some of the new efforts to create a care team that might not include the physician as much. And I think there's a lot of controversy around this because economically, a lot of folks are pushing advanced practice teams.
Sure.
But can you talk a little bit about, for those I would imagine who haven't read the article?
No one here has read the article. I know that.
I did. It's
Paywall.
fantastic.
It's behind a paywall. So.
A little bit about why you wrote that article and why you sort of stuck your neck out there for physicians, and what you think that means for 2020 going forward.
It wasn't so much in contrast to other professionals. It was really just this kind of, if you talk to most doctors today, they're pretty unhappy. And I think it's one of the biggest questions we need to grapple with as a healthcare system is how do we actually bring the joy back to medical care? And the inspiration for the article was actually a conversation I had with my father, who was a pain management specialist. He started the pain service at Memorial Sloan Kettering. And I watched his professional satisfaction go from very, very high at the start of his career to kind of a lower place over time. And he was still very proud of the work that he did and feels very accomplished. He recently retired. But usually he thinks I'm sort of like this bureaucratic doctor guy, and so the conversations are not that respectful. So he'll be like, "You don't know what you're talking about," and I'll be like, "Dad, I kind of know what I'm talking about." So long story short, some of his friends were over, and they were also physicians from Memorial Sloan Kettering, and I couldn't be my usual kind of combative self with my dad, and I couldn't shut him down. So I had to listen to these folks, and what actually became really apparent was this was like not just my dad, right? This is like a generalized phenomenon of loss of like satisfaction with the practice of medicine. All of these folks, top of their game, thoracic surgeon, urologist, started their services, true innovators, full professors, but they're like all grumbling. And so I finally just got really curious, and I said, so what was different? And they said, well, 30 years ago, if we needed a piece of equipment, if we needed something done in the institution, we were able to pick up the phone, we knew who to call and we could just get it done. And it wasn't for us as individuals, it was for our patients. Now there's a requisition form for literally everything. And we don't know who to call and no one feels accountable. And I started to see this less as these are unhappy people to okay, this is a problem of organizational complexity and scale. Mm-hmm. And what's been interesting about it for me personally, is it's just these institutions became bigger. And if you actually looked at the objective raw data of what happened in Memorial Sloan Kettering, the physical footprint grew 6x, the head count grew 10x. And so, the natural thing that happened there is that every single person felt smaller and less important. And so there's this thing that's happened is that this massive consolidation of physicians in America, everyone works for these big systems and no one feels like they matter anymore. And it's literally the worst thing that could happen to American medicine, I think, because in the end, if people don't feel valuable, they're not going to provide valuable patient care. That's just my take on it. And I've started to track the same problem within CareMore. So we've had a very aggressive growth path over the last 5 years. We grew from 4 states to now 12. We acquired Aspire. We're at 32. And 5 years ago, I literally knew every single physician in the company. And when they needed something, they called me. They texted me. They emailed me. They called me. They called me at 6 a.m. They called me at 10 at night. And it was small. And it was everyone felt big. And now we've gotten big. And now everybody feels small. And this question of how do you continue to make people feel significant, even in the midst of, all of this. And then, you layer on, the other part of your question was the care team. You layer on the kind of the subtle messaging that you don't matter because everyone matters, right? Which is kind of how people hear it, right? When they hear okay, there's this big care team now, and the truth is everyone matters, right? And so, we have a big part of kind of my management philosophy for the last 18 months is all right, how do I just get everyone feeling visible, right? So it's doing things like handwritten notes when people do things. It's recognizing as many people as you can on as many calls as you can, and you can never do that enough. And it's just trying to get the company feeling smaller. And it is my biggest challenge, and I think it is the biggest challenge of our industry, which is people will not do their best work if they feel like they're cogs in a machine. And and we've let people become cogs in the machine. That's what I think we've done, and that's what I think has happened. And that's why we get the care that we get. I mean, people were surprised when that paper came out in New England Journal a couple of weeks ago that said hospital consolidation has not improved clinical quality. I'm like, duh. What did you think was going to happen? Suddenly everything was going to get better. And it's also the other piece of it, which is I think we've started a quality measurement industry that is just like crushing people. We have 7 different systems that we're all trying to track, 7 different reward systems driven by payers, driven by and we've created a whole new enterprises. And the truth is we need to simplify it. We need to kind of boil it down to the few things that actually matter. And that's because people, when I first started doing organizational goal setting for CareMore, I used to and Serena knows this, Serena's my chief of staff, she's here. We would have 45 goals. And when you have 45 goals, no one knows none of them matter, right? So people are like, hey, you're kind of like an inexperienced CEO, stop doing that. And I was like, oh, okay, that's good. That's good help. That's very helpful. So now it's fewer goals, and with quality measurement, I think we've just done the same thing. We've just bombarded people with stuff. So, it's my college roommate's an engineer. He's like, you're just bolding the whole essay, is what he would used to tell me. You're highlighting and bolding the whole essay. And that's what I think we've done as a field, is we've kind of highlighted and bolded the whole essay, because everything matters. When everything matters, nothing matters.
Yeah. Yeah. My dissertation 20 years ago was hospital consolidation doesn't improve cost or quality, and nothing's changed. I won't tell you which organization that was about, though.
Partners.
Okay, so I've forced you to wear both the health services research hat, the CEO hat, the physician hat. I've gotten through the questions that I wanted to get through for right now. Can I open it up, and does anyone here in the audience have a question for Dr. Sachin Jain? We've got one right in the front. Bryn, right here.
Hello, I'm Sarah. I was just wondering about your experience working with Merck and how that shaped your current position with CareMore.
That gets written out of my bio, huh? Yeah, so I had this really kind of trippy adventure kind of working in pharma for 3 years that gets written out of my bio. For me, going to work at Merck was kind of trippy, because if you're a Boston-trained physician, pharma is the enemy. But I got offered this really cool job. I was running digital health and real-world data for the company globally, and it was really interesting. And so I learned a lot about drug development. I learned a lot about how the pharmaceutical industry works. More importantly, I learned how large organizations work. Merck is a massive organization of global scale, 130 countries, 80,000 employees. I mean, it's just enormous. And so I learned a lot about how to kind of navigate organizations. And I think I was selected for my job at CareMore in large part because CareMore had just been acquired by Anthem, sort of a similarly scaled company, and they wanted a physician leader who could kind of navigate all of this. I'll say my time at Merck was short because I realized something. There's 2 people who matter in the pharma companies: the people who develop the drugs and the people who sell the drugs. No one else matters. And so I kind of quickly realized
the legal
that
team matters.
I quickly realized, yes, legal, regulatory, compliance, all these folks matter. But the guy who's trying to rethink digital healthcare delivery, it's a cool sounding job. It sounded cool at parties. I was Chief Medical Information and Innovation Officer. It was cool. If your title has innovation in it, don't take the job. That's what I learned. I mean, it's just because it's that thing that nobody cares about that they just want to stick over there, and that's what it usually means. So that was what I learned.
Great answer. Other questions?
Hi, my name is Leah, and I'm from CHLA, or Children's Hospital Los Angeles. So based on my limited knowledge of research, I know the term control groups and baseline measurements, things like that. How do you approach implementing strategy or innovation strategy specifically, or these research findings in an organization that spans states with such varying economic or political climates?
Yeah, so it's really, I mean, so we have, there's like matched cohorts in some ways, right? So we've got markets that look really, really similar. And so you can try something in one market and not try it in the other and just see, like actually measure and see what happens. So turns out we have about 14,000 patients we take care of in Tucson, Arizona. We've got a similar number that we take care of in Las Vegas. They're similar in a lot of ways, and the populations are very similar from a risk perspective. And so again, every time we talk to an external evaluator about like, hey, how can we study the effect of X or Y? We always offer them Tucson and Vegas because it's this really great kind of very similar cohort of patients that we have. So I think, and similarly, we have different clinics that look similar in the same geographies within LA County, within Orange County. And so I think it creates a neat, test bed in which to pilot things.
Hello, I'm David Delgado. I'm with Providence, program manager with Providence. So you spoke to death by 1,000 metrics and kind of how that can put a stranglehold on the individual. But then you were also talking about system management and your ability to take something to scale very rapidly to now 32 states. And so I'm wondering if you can speak a little bit to kind of the inflexibility and the juxtaposition that having the metric as kind of the end-all be-all for some people, and how that can play at odds with quality. And also, I'm wondering if you can speak specifically to behavioral health and how some, especially within a field that it's hard to put a metric on, how you can take something such as behavioral health and spread it to a system as broad as yours.
Yeah, so I'll take the first part of your question first. So I'm not anti-metric. I mean, I want to be really clear about that. I'm just right metric, and I'm like metric for a purpose. And so like there are a few numbers we look at every single day at CareMore. Like every single day we wait for this email to come out that says how many patients we have in the hospital. And in our world where we're fully at risk for all the medical expenses for the patients we take care of, we don't want our patients in the hospital. Very different than if you're running a hospital system where you're like, we need 100% occupancy. We need sick people. We need some people to get some wounds. We need some, you justify that by saying, well, we want more of the patients and the other hospitals don't want them. But at the end of the day, like our world is all about kind of keeping patients out of the hospital. And it's this very true metric that I think, we look at every single day. And obviously we have to kind of continue to assess the appropriateness of kind of where we place patients and making sure we're taking care of them safely. But at the end of the day, given the level of iatrogenesis, given the focus on upstream management that we have in our system, we think that is the one metric. It is not perfect, right? It relies on a lot of professionalism to kind of make sure that we're actually kind of achieving that in an ethical way. We believe we are, but that is something we look at every single day. But again, if I said to you, here's 75 metrics and look at those every single day, which we've done at various times, it doesn't actually work, right? It doesn't change behavior. I mean, the reason you actually the reason you're measuring things and putting them in front of people is to try to drive behavior change. And so it's just, I think we've gotten very lost in terms of not being able to really connect why we're doing this in the first place. And it's become that we're doing it for US News and World Report. We're doing it for the regulators. We're doing it for the STAR measures. We're doing it for the payers. But like the real reason to do it is for the patients. And I think that's the thing that sometimes I think has gotten lost in our quality measurement world. And Don Berwick, my college professor, I was with him last summer, and it was like, I was just like blown away because he was like, yeah, we kind of blew it. Like we have too many measures. I was like, you just spent 20 years doing this. Like, what are you doing, Don? Like, so I mean, like that. I think that's kind of some of the things I think about. So on the behavioral health side, like what I believe is that we've over-specialized everyone. And we've sliced and diced everything. So people will say, like, we have a behavioral health access problem. Okay, so what does that mean? It means that we have generalist physicians who are saying, I'm not going to take care of any behavioral health problems, and I'm going to just stick them in all these other places. So we have to have therapists, and but the truth is that like one of the kind of, I think, missing things in our healthcare system right now, as we've kind of created more and more focus on tertiary and quaternary, high margin, high volume business, is the idea that like all of us should be able to take care of some set of issues and problems. And like as a clinician, as an internist, as a generalist, like some of the most satisfying clinical care that I provide to people is behavioral health care. You know, in other systems, these folks would get sent to, you know, a psychiatrist to get initiated on an SSRI. In our world, we really want our generalists to be doing this. Confident generalists is what we call them, because at the end of the day, care gets worse when you start dividing it among 50 people. It just, you know, that's just a principle of how it gets, of organization and delivery. So when you start thinking about the healthcare system of the future, where we need to try to drive things, my personal view is we need to kind of institute the value and power of the confident generalist. That's something that I think, you know, people who live in small communities intuitively get, where the primary care doctor is doing all of it for you. And the reason they're confident isn't because they've like trained in all these things, it's they've just seen it. They've been in a position to do it. And, you know, again, I think the way we pay for care has made it so that, you know, rather than actually taking the time to actually listen to the patient, understand what they need, and solve their behavioral health problem, or work with them to address it, not necessarily solve it, we instead say refer to therapy. Like that's what that clinical encounter looks like. And how unsatisfying for you as a clinician, how unsatisfying for you as a patient. And then we're like, oh, the patient was not compliant because you've now, at the moment that they were vulnerable and seeking help, you've now just implemented a 3-month wait for them to actually get the help that they need. So that's where we all have to take more accountability as individuals, as professionals, as people who deliver care, to actually do as much as we can in the moment. And I think we have to stop. And you know, I've similarly said the same thing about pharmacists. I mean, have any pharmacists in the audience? This is a big problem. I mean, they're probably doing something on their Tuesday night. But the issue with pharmacists is, like, they're actually super qualified to do a lot of stuff that we don't actually license them and empower them to do. So much of what we've been trying to do at CareMore has been trying to empower pharmacists to do a lot of chronic disease management, because they actually do a really good job of it. The other thing about pharmacists is that they are really great interprofessional teammates. You know, ask someone to name a doctor or a nurse who's bothered them, they'll like list 20. Nobody can name a pharmacist, because pharmacists are trained to be collaborative, collegial, like, doctor, did you realize you almost killed a patient? Like, you know, so I'm just, you know, I really believe that we just have to kind of broaden everyone's scope a little bit. The other thing that I think we need to do from a design perspective, to just harken back to your previous question, is I think we've gotten really skewy with, like, you know, how we organize and structure who actually delivers care to which patients. And so, you know, some organizations are like, let's scale this model and take care of all the sickest patients in the world by hiring a bunch of fresh graduate nurse practitioners. You know, that may work in some setting if they're supported and if they have the kind of backup. But, you know, we've actually gone down that road sometimes. And what those nurse practitioners will tell you is they're terrified, because they're taking care of basically ambulatory ICU level type patients by themselves, unsupervised, without backup, without support, without a team. And so, again, I just think we have to think differently about how we play together as teammates and make sure people are in a position to succeed, you know, more of the time, not less.
I have to tell you, there's a seasoned dentist that went through the executive MPH program, and she's the first person that I ever heard use the phrase, it's time to put the mouth back in the body. And we have really great oral health scholars, and it was such an eye-opening thing, because we have carved out all of these different systems and just put them over here and don't see that it's a whole system of care that's often needed by some of the most just people we see on a daily basis.
Yeah, so we, you know, at CareMore, we've actually integrated dental into one of our clinics with this idea that the dental encounter should be an encounter where you actually do chronic disease management.
Yeah.
So, you know, we're checking hemoglobin A1Cs and blood pressures at dental visits, because that's an appointment that people love their teeth, so they come in for their teeth, and they may not come in for their blood pressure or their diabetes, but they're going to come in. But they're going to come in for their, you know, and so we embed nurse practitioners at the dental chair side.
Yeah, great. I think we have time for maybe just one more question. Oh, tough call. Sorry.
Hi, I'm Frank Matricardi with Executive Healthcare Consulting. You mentioned CareMore as a risk-bearing organization. So think about what happens after November. Are we going to have more medical groups, the delegated model that we have in California? Are we going to have capitation? What do you think might happen?
Yeah, so this is like an off-the-record, unofficial opinion. I mean, these are the kinds of things that get you in trouble, fired, put in a. What I will say is, my personal view is that eventually there will be some version of Medicare Advantage for all. And the reason I think it would be a distinctly American solution, right? It's the private sector delivery of an entitlement program. I'm not saying I personally think it's the best. Like, that is just from where I see the world going. That's where I think it lands. Eventually, in 1 or 2 cycles.
Actually, I've been signaled that we have time for just another couple questions. Thanks. Right here? Do you have a question, sir? Oh.
Hi, Dana. I'm on the business side of life sciences for many years. I know that you worked at Merck, and I know that within large pharma companies, there's often tension between research teams and the business side of the company in terms of whether to pursue a particular course of research and development for a drug or something, because if they spend hundreds of millions of dollars researching a particular treatment and it doesn't work out, it affects the company. That's as opposed to, let's say, an early stage company that's not a large pharma. Maybe you can talk about the tension between business and research within a large company because you were at Merck. And the other question I have is, in the life science ecosystem, we have all these stakeholders, insurance companies, investors, patients, doctors and nurses. And it seems to me that communication between all of these stakeholders is going to have to be key if we're going to make any progress with innovations and breakthroughs with vaccines and other things.
Yeah, so, your first question, I reported directly to the chief medical officer of Merck, and his job was to really kind of be the voice of medicine and patients in the system, and to really kind of provide that conscience and to kind of represent those voices in those business decisions around balancing kind of commercial interests and scientific interests and what was really good for patients. And I think this is where, it's a quaint word in 2020, but professionalism really matters. And, like having folks who are kind of guided by something more than just the business interest that is in front of them at the time. And I think it's really important for organizations to embed people like that in positions of authority and oversight, because we see this, leave healthcare for a second. I mean, you see what happens at Wells Fargo or Enron, or, when you have kind of unbalanced motives that are unchecked, I think you end up seeing a lot of skewy decision-making. To your second question, having worked, not being able to hold a job in government, pharma, the payer sector, the provider sector, academia at a VA, these are all places I've spent time. What I struggle with is how much demonization happens across like all of these different sectors of healthcare. And the truth is that there are demons in every sector of healthcare. And there are people there are bad actions in every sector of healthcare. And I think, unfortunately, every one of us gets whatever sector we sit in, we feel like we are somehow superior to the other sectors. And I think a lot of why we have the system that we have is that there is that lack of cross-sector pollination, that lack of, I think, respect for what happens in the other places. Again, this whole issue of being raised essentially in a pharma-schooled environment, right? We need great drugs. We need phenomenal medicines to actually solve clinical problems that are presently unsolved. People forget that sometimes. I was at Merck when pembrolizumab, also known as Keytruda, you probably see a lot of Keytruda ads all over. It's a very expensive drug. It's basically changed the course of cancer care by introducing cancer immunotherapy. I mean, as a viable approach to in melanoma. Jimmy Carter is alive today because of pembrolizumab. There's this ability, for folks who sit in other parts of the healthcare system to say, "Oh, bad pharma." You're starting to see this now happen with hospitals and physician groups around surprise billing and around the costs of hospital stays and kind of the bills that people get from hospitals. So there's just this intense pressure to kind of point the finger at the other guys so that no one's looking at you. And I think this is where leadership actually really matters. We kind of have to look at the whole thing together. and start to recognize that like everybody's got, for things to get better, somebody's got to lose. And we kind of live in this world where like everybody's got to just keep doing better and better. Like that's the healthcare industry in America right now. And we just kind of have to start to recognize that you're going to need to make trade-offs. Maybe we need fewer hospitals in America. Maybe we need smaller hospitals. Maybe we need, more pharmacists taking care of patients with chronic disease, which means less volume for physicians. Like there is a massive kind of need to like look at the whole thing. And I think we just don't do that. And again, the politics of healthcare reform are ugly politics, and it's all about blaming someone else. And I think we have to exit the cycles of shame and blame.
Yes. Sir. Oh, you're back here.
Yes. Hello.
We will get to you.
Hi, my name is Phil. I'm a member of Anthem's digital group. Before my question, I just want to say that I've had the pleasure of following you on LinkedIn and Twitter, and I find your candidness very refreshing on this platform.
Thank you.
My question is this. You talked about the consolidation of provider systems from your experience scaling your own organization. How do you see the role that technology either plays or doesn't play in helping providers avoid feeling invisible?
But first of all, you don't call them providers. Not to pick on your question. I just think we have to kind of call people like at the level of training that they exist, and call physicians physicians, call nurses nurses. I think we have to get out of this kind of anonymization and you're basically using provider as a term to be like Joe healthcare worker. So we got to get out of that. So please do that. So second thing on the digital side, I think digital needs to be organized to unlock the humanity that patients deserve and that people want to provide. And I think too often we think about it as a substitute. And the fundamental act of most medical care is behavioral change. You're trying to get for people with chronic disease, you're trying to get people to change their behaviors. So if technology can augment human connection that actually can drive behavior change, that's great. But I think in chasing liquidity events, in chasing sexy quote unquote innovation, I think we oftentimes like lose what matters most, which is like people, their families, the people who deliver care, their satisfaction, recognizing that their satisfaction influences what kind of patient care gets. We've cut so many corners, and now digital is being used as kind of like this great corner cutting activity. Like, oh, let's just put AI in there so we don't have to have any people involved. And there's places where you should do that, right? There's processes that we should automate for sure, no question. But I think again, we're taking this brush and we're painting it over everything, as opposed to being selective, as opposed to being targeted, as opposed to being thoughtful about it. And I think that is the opportunity, is to kind of again like recognize that this is a human endeavor. The delivery, it's actually a lot more art than science. If like the delivery of care. And I think that's one of the things that I think people who actually practice medicine will tell you is like there's so much we don't know, and like there isn't evidence that informs like a whole bunch of the care that we deliver. But I think folks who haven't spent time in actually care delivery assume that there's way more scientific underpinning, and so then there's this like drive to take like these non-scientifically validated insights and approaches and then drive them into a digital solution. And it just doesn't work for that reason. So my view is like there's a lot of good work to be done, but I think it all starts with like basic principles around like respecting the fundamental humanity that we're trying to bolster in patients and people and that kind of thing. But thank you for the question.
Thank you very much. I'm interested in knowing your relationship with Anthem Blue Cross. How did CareMore and Blue Cross come together?
2011, Anthem wrote a big check to some people at CareMore. And they're like, give us your company, and now it's a company.
What about the Anthem? Don't they still have their Medicare program, the Medicare Advantage? Is that different? Or?
Yeah, no, so it is the CareMore Medicare Advantage products are now, CareMore is now the provider entity, and the health plans have been rebranded Anthem Health Plans. So what were formerly CareMore Health Plans are now Anthem Health Plans, with CareMore as the provider network. It's kind of how we operate.
Staff model?
So it's a hybrid staff model, network model. So we operate clinics that either provide primary care or chronic disease management, and then we operate We have extensivists, which are essentially hospitalists who follow our patients, who take care of our patients in the inpatient setting, but they also continue to take care of them in SNFs, as well as in post-discharge follow-up care. And then, our model varies depending on the market. And in a lot of our newer deployments, we're doing home-based primary care, we're doing home-based chronic disease management. It just depends on the geography and the volumes that we're taking care of.
Lastly, I'm interested in when you talked about the behavioral health and the integration of medicine and the behavioral health, because for me as a doctor, I thought that's the direction it should have been. It's like a tremendous waste of money running a parallel mental health system, medical system, because as a doctor, 60% of people we see have
behavioral health, for sure.
Blood pressure, diabetes, depression, anxiety.
It's all denial.
It's like a waste of money.
Yeah.
But, right, in the past 2 weeks, the state of California, the LA Care HealthNet, they've approached us to do a 3 years program to integrate regular patients and psych patients. They are going to fund us. I run the chairman CEO of Global Care, 200 patients and 3,000 doctor group. We're one of the largest groups we have that we do medical, Medicare, and commercial. But this is something the government want to try out, LA Care and HealthNet. So you're ahead already. You're in the right direction.
Thank you. No, I appreciate it.
I know, she's getting her workout.
Hi. Natalie Sanchez, my field of work, I'm a graduate of the UCLA EMPH program. I'm now at UCLA, but my experience is in HIV. And so I agree with you around generalizing healthcare. And so my question to both of you is around health equity. What is the role health equity plays in the Center for Healthcare Management? So given my experience in HIV healthcare is that we see a huge disparities and that communities of color are most impacted. And I think our downfall is that we're trying to take the standardization and the approach for the general community and trying to apply that to communities of color, and what we're seeing is a failure. So question is, how does health equity come into play for the Center of Healthcare Management?
So given we're still in the early stages of the center, I guess the best answer to your question would be that we really hope to be a home, to be the place where people like yourself who are practitioners, who've been out there working, who understand the nuances and the difficulties of actually getting to the root of health equity and the delivery of that care, can work with people who can either write, establish, build evaluation methods, do a study, find some comparative groups, and be able to create some evidence around it versus so much of us knowing that it's there, but we know it through either intuition or we don't have it well documented. There's a lot of interest in the Fielding School around this and a lot of research being done, but it's so across UCLA, the School of Law, the School of Public Policy, School of Medicine, School of Nursing. So our hope has always been, with the vision here, to be able to create this place where the scholars and the practitioners can talk about it and then try to create an opportunity to get at the root of it instead of it being so dispersed that we never really make any progress. It just seems like everyone's intuition answers the question versus having evidence to answer the question, and we need better evidence and better studies. Laura, I don't know if you want to add anything more to that, but we look for that kind of collaboration, and we really think the center is kind of a unique opportunity, instead of it just being a research center, to work with people like yourself who just have been living it every day, and the work you've done has been so novel. So please be involved. Reach out to us. We look for the opportunity to make those connections.
So my name is Nicole. So I'm running a student organizations on campus focusing on health tech consulting. So we help like health tech startups, like digital health companies, to like bridge the gap between them with the traditional like healthcare practices, because we really believe that can help like the healthcare innovations in the futures. So I'm really interested in like your role like before in Merck, that's as a the innovation. So
Don't do it.
Don't take the title.
Don't do innovation. I'm just telling you.
So I want to understand like how do you have you like implemented or deployed any of the digital health like at CareMore, and like what are the benefits you see so far, and what are some barriers for traditional like practices to adopt like digital health?
Yeah, so we've actually built our own digital center, all jokes aside, and the focus is really on solving what I think of as like unsexy problems, like, you know, how do we automate processes? How do we get better translator services into the exam room? How do we use text messaging to drive like real two-way asynchronous communication with patients? We're trying to virtualize a lot of care. There's places where we have excess and excess capacity that we're trying to virtually make available to other places. So a lot of what we're trying to do is just solve these kind of like basic run the business kind of problems, and bring in digital solutions to kind of automate things that are otherwise highly manual, or, you know, just perform suboptimally. So we have a VP of digital. His name is Omid Taloui. And if you have a startup you're trying to work on, or a digital solution, please talk to him, because he'll, you know, let you know if it's useful or interesting to us. And he's an alumnus of the school, I think.
And used to work for the Senaico Consulting
Yeah,
Group.
there you go. Yeah.
So,
and he's terrific. So
yeah. Interesting.
Yeah.
All right, so thank you so much for your attention. Thank you so much, Sachin, for
Awesome. It's an
your
honor.
thing. I think Laura's going to say a couple words, and then we'll exit.
So I hope all of you enjoyed tonight as much as I did. I just found myself so interested, and I had questions, and then I would forget them because I would get distracted by the next point. And so thank you for joining us. Thank you for coming. Thank you to Dr. Jain. Thank you to Dr. Vriesman. Thank you to everyone who was involved in putting on tonight's event. Huge thank you to our super generous donors, Richard and Greg, Tom. Thank you to the Health Forum Planning Committee and to Mike Galper, who chairs that committee. And you know, it wouldn't be a healthcare Center for Healthcare Management event if we didn't plug the fact that we're always looking for donors. So we welcome your support for the Center for Healthcare Management. We welcome your support for the Paul Torrens Chair in Healthcare Management and for the Paul Torrens Health Forum. And if you'd like to make a gift, we've made it so easy for you because there's a QR code right in your program. And so everyone in the audience, except maybe my dad, knows what a QR code is, and it'll take you to a secure giving site. So we appreciate anything that you want to contribute. We hope you enjoyed tonight's program. Our next Paul Torrens Health Forum is on February 27th, and we are going to explore immunizations and what some of the policy implications are of immunization and immunization resistance. As noted in the program book, the Health Policy and Management Alumni Association will be hosting their annual dinner, the Leaders of Today, Leaders of Tomorrow dinner, on May 28, 2020. So put that date in your calendar. It's always such an amazing event, and please plan to attend. Have a great evening. Get home safe. Thank you so much.
Thank you. Thanks a lot.
Wonderful.
Thank you.